Hope you guys are safe and healthy. This is my first video and I want to talk about the physiology of CNS. I hope you guys like it and forgive me if I make any mistakes. So let's get into it. We'll talk about the cerebral metabolism. So mainly we have to know about the oxygen consumption and the glucose consumption. So oxygen consumption is measured by CMRO2, which ranges at around 3 to 3.5 ml per 100 gram per minute normally, and it is a product of the cerebral blood flow and the difference between the arterial and venous oxygen content. Brain utilizes around 20% of the total body oxygen consumption, and if the brain does not get any blood supply for around 3 to 8 minutes, the ATP stores are depleted and there is irreversible cellular injury. Of all the structures, the most sensitive is the hippocampus and the cerebellum. Now let's see the glucose consumption of the brain. So primarily that is the energy source for the neuronal cells, and the brain tissue utilizes around 5 mg per 100 gram per minute. In hypoglycemia, you can see irreversible cerebral injury, and in hyperglycemia, you can see there is increase in global and focal hypoxic brain injury. And hypoglycemia forms a substrate for anaerobic respiration, because of which the lactates increase and will cause cerebral acidosis. And here you can also see that the inflammatory cells are increased and there is free radical formation causing endothelial dysfunction. So cerebral blood flow can be measured by using Ketty-Smith's technique, which uses 10% nitrous oxide inhalation. There are other methods such as the intracarotid injection of 85 krypton, 133 xenon, inhalation of radioactive xenon, PET with short-lived isotopes such as 11 carbon for glucose and 15 oxygen for oxygen, and transcranial Doppler. Some of the important values which we need to memorize are like the global CBF, which is 50 ml of blood per 100 gram per minute, which accounts to around 750 ml per minute, that is around 15 to 20% of the cardiac output. This happens because of the rapid metabolic rate of the brain and the absence of the oxygen stores. Now, when you see there's the regional CBF, you see the gray matter has around 80 ml per 100 gram per minute of the blood flow, while the white matter has around 20. So the critical global CBF is the blood flow below which the cerebral ischemia occurs, and you can see a slowing EEG, and this occurs when the blood flow is around 20 to 25. The critical CBF under anesthesia is 18. When you use isoflurane, it is 12. So if the blood flow is 15 to 20, you see a flat isoelectric EEG. But if it is less than 10, then there is an irreversible brain damage. To avoid this, the brain starts regulating its blood flow. And to know this, we have to know about the partial pressure, which is nothing the pressure which is required to drive blood to an organ. Now, the partial pressure is the difference between the forcing pressure and the opposing pressure. And here you can see that it's the difference between the mean arterial pressure minus the ICP plus cerebral venous pressure. But here CVP is 0 at the jugular venous bulb, and it's easier, and ICP is easier to measure, but you can take CVP when it is higher than ICP. Let's see the normal values of CPP. It is around 90 to 100 mmHg. So less than 50, you have a slowing EEG. 25 to 40, you have an isoelectric EEG, and less than 25, you have an irreversible brain damage. Now let's see the the effect of increased ICP on CPP. The perfusion pressure is usually maintained till the ICP rise of around 30 to 40 mmHg, where it is significantly decreased. In Cushing, you can also see the Cushing reflex, where any increase in the ICP causes a reflex systemic hypertension and also brady. This bradycardia occurs because of activation of the baroreceptors, which in turn increase the cerebral perfusion pressure. So let's see some of the factors which increase the CVP. Mainly, you can see that any head down position, any increase in the intrathoracic pressure, intra-abdominal pressure, increase in the blood volume, or increase in the venous stone or venous obstruction, as can be seen in SVC thrombosis and venous sinus thrombosis, will cause, all these factors will cause an increase in the CVP and increase in cerebral venous pressure and increases the ICP. So how does the brain regulate it? So the brain has the intrinsic and the extrinsic mechanisms. That is, in intrinsic mechanism, We'll talk about the autoregulatory curves and the extrinsic mechanism. We have other factors such as the respiratory gases, then the pH, temperature, and the viscosity. So, intrinsic mechanism here, the cerebral autoregulation is nothing but the ability of the brain vessels to tolerate any wide fluctuations in the MAP with little changes in the blood flow. But this occurs and can be maintained only from 50 to 150 mmHg. And you can also see that if there is a decrease in the cerebral blood flow, the perfusion pressure is decreased and the vessels in the brain will start vasodilating, and there is increase in the blood flow. And if the blood flow is increased, the cerebral perfusion pressure is also increased, then we have vasoconstriction and the blood flow decreases. So these are autoregulatory methods. This work only from 50 to 150. But here if the MAP is less than 50 or more than 150, it becomes purely pressure dependent. So here we see a scenario where the MAP is more than 150, then you can see that the blood vessels are maximally constricted, and but the blood flow will keep increasing as it is pressure dependent, and there will be over distension of tissues causing cerebral edema. And if it is less than 50, the cerebral blood flow maximally it is dilated, but the cerebral blood flow decrease. I'm sorry, if it is less than 50, the brain blood vessels are maximally dilated, but here the blood flow decreases as it is pressure dependent, and you can see cerebral ischemia. Let's see some autoregulation curves. Here, as you can see, on the y-axis we have the cerebral blood flow, and on the x-axis we have the mean arterial pressure. The purple one is a normal curve. So any shift towards the right is because of vasoconstriction, towards the left is the vasodilatation. Here, some of the factors which cause vasoconstriction is hemorrhagic hypotension and arterial hypertension. So these hemorrhagic hypotension can be caused because of excessive sympathetic activity, and the vasodilatation, that is the leftward shift of the curve, is caused by sodium nitroprusside, which is more, and also trimethophan. Now let's see where the autoregulation is completely abolished, that there is no vasodilatation and vasoconstriction. So this can occur in hypoxia, hypercapnia, premature infants, and some conditions where there is acute increase in the ICV, like the head trauma, intracerebral tumors, and the inhibition of nitric oxide synthesis. So here you can see that the inhibition of nitric oxide synthesis will abolish the intrinsic mechanism, and it will abolish the cerebral vasodilatation in response to all these factors such as hypercapnia, hypoxia, and volatile anesthetics. So let's see the mechanism. They are myogenic and metabolic mechanisms. So myogenic is nothing but the intrinsic response of the smooth muscle cell in the cerebral arterioles to any changes in the blood pressures. So as the blood pressure, that is the mean arterial pressure, increases, there is increased distension and there is contraction of the arteriolar vascular smooth muscle. This contraction of this smooth muscle will cause decrease in the arteriolar diameter, because of which there is decrease in the cerebral blood flow. In the metabolic theory, there is release of various tissue metabolites such as any release such of nitric oxide, adenosine, prostaglandins, electrolytes will cause vasodilatation, and there is increase in the cerebral blood flow. Usually the endothelin this will cause vasodilatation. In contrast, the endothelin release will cause vasoconstriction. And there are three isoforms of this endothelin, ET1, ET2, ET3. Now here you can see two scenarios where there is first one is there's increase in the metabolic rate in case of pain, anxiety, convulsion, where the blood flow is increased. But as the metabolic rate decreases, as in case of hypothermia, barbiturates, and diazepam, there is a decrease in the cerebral blood flow. Let's see the extrinsic mechanism. In extrinsic mechanism, we see the respiratory gas tensions. PaCO2, that is very, very important, as the blood flow is directly proportional to PaCO2. And the limits are around 20 to 80 mmHg. So if the PaCO2 is high, there is cerebral vasodilatation and increased in the blood flow and ICP. If the PaCO2 is decreased, there is cerebral vasoconstriction and decrease in the blood flow and ICP. Cerebral blood flow usually changes for around like 1 to 2% per 1 mmHg of PaCO2. And let's see what if the PaCO2 is less than 20, then there is maximum vasoconstriction. If the PaCO2 is more than 80, then there is maximum vasodilatation. Now when we graph, in this graph you can see that in the y-axis there's the cerebral blood flow and the x-axis has partial pressure. You can see that the changes in PaO2 such as PaO2 less than 50, you can see marked change in the cerebral blood flow inversely. But if PaCO2 is more than 50, you have very little change of the blood flow. And when you see PaCO2, the graph of PaCO2, the effect is immediate because CO2 crosses the blood-brain barrier easily and causes pH changes of the CSF and the brain tissues. Here the pH is the main driving factor and the release of H plus ions. Interestingly, you can see that after 24 to 48 hours from the cerebral blood flow changes, due to any change in PaCO2, bicarb from the CSF tissues tried to compensate for this effect. And but this compensation is not immediate as bicarb doesn't cross the blood-brain barrier as much as carbon dioxide. So here this concept can be used in the head injuries where mild hyperventilation and maintaining a PaCO2 of 30 to 35 mmHg will decrease the ICP and is beneficial. So it's better to always avoid aggressive hyperventilation. Now let's see some other factors which influence the extrinsic mechanism. Here you can see the extracellular pH, that is the H plus ions, they do not cross blood-brain barrier and there is very little effect. Example, it can be seen in acute metabolic acidosis and temperature. The blood flow varies directly with temperature, that is around 5 to 7% per degree centigrade. That is till 42 degrees centigrade. When the temperature increases, there is vasodilatation. Because of vasodilatation, there is increased blood flow and increased CMR. But after 42 degrees, the CMR decreases due to cell damage. The EEG is also isoelectric. Now, if the temperature is decreasing, there is vasoconstriction and decrease in the cerebral blood flow and CMR, and the EEG is also isoelectric. This happens if the EEG is isoelectric only when the temperature is less than 20 degrees centigrade. Yeah. And the other factor is the blood viscosity, which is determined by the hematocrit. So hematocrit 30 to 50% has little effect on the cerebral blood flow. Beyond these limits, cerebral blood flow will vary inversely with hematocrit. That is less than 30, there is increase in the blood flow. This occurs in cardiopulmonary bypass. But if the hematocrit is more than 50, then the blood flow decreases as seen in marked polycythemia. So that is about the extrinsic mechanism of autoregulation, and I hope you guys understood, and forgive me if I made any mistakes. So I'll just attach these files for you guys to study, and I hope it really helps you. Take care. Bye.